physical activity, the CDC recommends at least 250 minutes per week of aerobic activity. So you can work out that. So 250 minutes per week, and strength training at least twice a week. So here we all are at the JCC, and good place to start for that. As far as the physical exam, blood pressure should be checked at every visit. Looking for a cutoff of the task force looks at a number of 140/90 with a lot of exceptions. Okay. BMI should be measured every visit with a goal of 19 to 25, that's body mass index, with cutoffs of 25 to 30 for the overweight category and over 30 for obesity. As far as screening for chronic diseases, the task force recommends screening for diabetes in anyone. This is a little not so intuitive, but screening for diabetes with anyone with a blood pressure of 135/80. The American Diabetes Association recommends anyone 45 and older to be screened for diabetes. It doesn't mention much, surprisingly, about family history and other risk factors and that sort of thing. So that's not in the guidelines, although it's something that people are doing kind of anecdotally or
Question.
Yes.
Would you be sending people for a basic metabolic panel anyway at that age, and there'd be a glucose level there, or is it something different that you're doing specifically for diabetes screening?
It would be something specifically for diabetes screening with a fasting blood sugar. We can talk a little bit about blood work, but since you brought up a lot of the quote routine lab work that historically has been done with chemistries and blood counts and urinalysis and all that sort of thing is not really part of the guidelines. The evidence-based medicine says really to try to steer away from that. So that's diabetes. For dyslipidemia, high cholesterol, it's recommended for all men 35 and older, and also age 20 to 34 with cardiovascular risk factors such as hypertension, diabetes, etc. Next would be abdominal aortic aneurysm screening, which is found in 5 to 10% of men, ages 65 to 79. So fairly common and can be a pretty catastrophic thing. What's recommended by the task force is a one-time ultrasound screening between ages 65 and 75 for anyone that's ever smoked. So as part of the Welcome to Medicare visits, if you're familiar with that, and Medicare screening, it's also included, but it doesn't quite fit into those task force guidelines.
Do they have a screening program at Lehigh Valley? And I'll give you an example. At St. Luke's, the vascular surgery group, I think for $30. I mean, you can just basically pay $30 cash out of pocket, and you go to the vascular lab. They do carotid ultrasound. They look at the abdominal aorta. I'm trying to think what else they might look at. Just peripheral blood flow, some type of test to the feet, just to rule out peripheral vascular.
And those things are common, and those things are marketed. Some of that is marketing, and if you're strictly going by guidelines and what is evidence-based, that's a different story. Move on to osteoporosis briefly. The task force does not recommend screening men for osteoporosis. So there's some differences of opinion. The National Osteoporosis Foundation recommends DEXA scanning for all men over 70 and those 50 to 69 with risk factors. So there's some difference of opinion there. The Institute of Medicine recommends adequate calcium and vitamin D intake. There are recommended numbers and amounts, but that's a controversial topic also, how much vitamin D, how much calcium to take. You'd think it would be straightforward, but it's not so clear cut. The task force specifically says not to screen for COPD. That's something that's been done in the past, years ago. People got chest x-rays, people got all kinds of screening, spirometry, etc. but not specifically recommended. One thing that's relatively new, which the numbers show is not being done, but there are new CDC recommendations for a one-time hepatitis C screen, hepatitis C for the baby boomers, those born from 1945 to 65. So one-time hepatitis C screen. And then we'll move on to cancer screening, which you've heard a little bit about colon cancer, and kind of leave it at that. And prostate cancer screening. We'll just mention that at this point. As far as the guidelines go, skin cancer screening, there's often talk about having a full body scan, but the evidence is not very conclusive as to the benefits of that, at least as far as the task force recommendations. Same thing with testicular cancer, and I don't know what is recommended by the urology literature, but at least in the task force recommendations and the National Cancer Institute do not recommend routine testicular cancer screening. Other things like immunizations, highly recommended annual flu shots for all adults, strongly encouraged. Okay. And then other things that we'll typically ask about, the recommended tetanus screening, pneumococcal screening, and zoster, or shingles, or discussing immunizations for those diseases. So that's a basic overview, and hopefully it's generated a bunch of questions. Yes?
I'll ask a non-doctor question
Okay.
for a second. So these task force recommendations, are they balancing the benefit of the test against cost and against, let's say, procedures that, resulting in procedures that were unnecessary or harmful, as opposed to just the benefit of the test period?
The way these are formulated, I think, is a huge undertaking, and I'm not sure the exact details of the meetings and all that sort of thing, but all of that is taken under consideration. The risks of the test, the cost of the test, the benefits, the inherent sensitivity and specificity of the tests, and then outcomes.
So when you're, as a physician, tied into these kind of recommendations, do you have the ability to offer different patients different options where you say this test is not recommended based on whatever government task force, but it's a viable test that I would recommend to detect or screen for cancer. We just have to manage the fact that it's costly, may cost you more money, and it may result in some type of procedure later on that could happen from a false positive or whatever.
Yeah,
or are you guys locked in to sort of, once you start doing that for patients?
Well, it's a good question. We're always balancing the science side of medicine and the humanistic side of medicine, and doing what's right for patients. All of these recommendations talk about people with no risk factors, and yet many people are kind of in a gray area. They're somewhere they're not high risk, but maybe there's a family history, and it might make you lean towards doing some tests that it might be a slightly different story. There's also issues such as a young, healthy 30-year-old male that the previous year you've done cholesterol screening, and their numbers are fantastic. And they come back a year later and say, oh, and nothing has really changed medically. They come back a year later and say, I really want my cholesterol screened. And you say, well, there's not really a good indication to do that. They're like, well, I just want to do it. And, you may end up saying, well, this, I'll pay out of pocket, whatever. And, peace of mind. And some people just want to know. And so peace of mind is a real thing. And that can affect, what you're doing.
Quick question,
Yeah.
Mike. You said about the shingles vaccine. Is that real effective? Because if you had chicken pox when you were a kid, you could still get shingles when you were older. So, and you obviously would have developed some antibodies. I would have thought.
Well, what happens is you will only develop shingles if you've had chickenpox in the past.
So how does the vaccine work?
It boosts your antibody response to the virus. The virus lays dormant in the body for
Oh,
decades.
so you've had you do
Yes,
have
you wouldn't
antibody,
get
but it's
shingles unless
not-
you've had chickenpox previously.
I'd like to go back to Gary's question, because I thought it was outstanding, and I thought it really relates to urology. The United States Preventative Task Force Service recently came out saying that we should not use PSA. This is I mean, your question was so appropriate here. So here I was going to briefly start talking about prostate cancer screening, and talk about all men at age 50 should get an annual digital rectal examination and a PSA level, or at age 45 if there's a family history, first-degree relative, or African American. And suddenly the United States Preventative Task Force comes out and says, we shouldn't do that test anymore. So what do I do as a urologist? Well, there are two things I'd like to mention first, because my academy completely disagrees with that recommendation. So now you have the American Urologic Association saying, do not listen to the United States Preventative Task Force Service. You have the United States Preventative Task Force Service, which was a commission basically by the government, unpaid professionals by the government who came up with this recommendation. And then you have another piece of the puzzle, which is Medicare, whether or not what they're going to pay for. So we're going to talk about those in a sec. The two things I would like to bring up first is, number one, a slide that I commented on in the middle of David's talk. In 1988, 1989, you saw a dramatic spike in prostate cancer incidence. And there's over 200,000 new cases of prostate cancer a year in the United States, the most common solid organ tumor in men. And subsequent to that, the rates of death from prostate cancer decreased dramatically. So now suddenly you say, well, there's a test out there that since that test has been around, we have diagnosed more prostate cancer and we have dramatically lowered rates of death, but yet we're told that we shouldn't do it. So a couple things about that. Number one, our organization lobbied Congress aggressively, and after that United States Preventative Task Force Service recommendation came out, because that's not a law, it's not something that has to be abided by, it's just a recommendation. Congress actually put in a provision very shortly thereafter, based on lobbying from physicians, that Medicare will continue to pay for PSA testing. So we as urologists, I haven't really changed much. But to the latter part of your question, which was so appropriate for this, was, well, what we were doing with PSA, that was the problem. And a lot of urologists were guilty of it. And probably I was guilty of it as well when I first started in practice, where you take a guy who's 71, and he has a PSA greater than 4, which prompted a biopsy. His PSA is 5.2. He ends up getting a biopsy. We do 12 cores of the biopsy. In one of the cores, 5% of one of the cores came back with Gleason 6 prostate cancer. Prostate cancer is graded on a scale from 6 to 10. 6 is the best cancer you can have, and I use that term loosely, and 10 is the worst. And what we were doing was we were taking guys, 71 years old, Gleason 6 prostate cancer, small volume disease, no signs of metastatic disease, and we're saying, oh yeah, you know what, you're going to do great with the Da Vinci robot prostatectomy. We're going to take your prostate out. And then these guys are suffering from incontinence and impotence. So the United States Preventative Task Force Service was looking at that type of recommendation, and the bottom line is, were we doing these guys a service? And the answer is no. And a recent study came out on the PIVOT trial. It was in the New England Journal of Medicine, and this was just very recently. I see some of the primary guys in the back shaking their head, because this was a real strong study, and it was basically saying if you're 65 or older, if your Gleason score is 6 or your PSA is 10, you will have really no difference in your survival if you are watched, if you have surgery, or if you're radiated. But the amount of side effects that you'll get if you have surgery can be significant. So I think that, again, going back to Gary's question, was right on when it comes to prostate cancer, and it has absolutely, that study changed how I look at things, and I'm counseling more and more patients, and I know my partners are doing this as well, and we are more and more doing what we call active surveillance for small volume Gleason 6 prostate cancer, and that is guys are saying, okay, you have Gleason 6 prostate cancer, the studies have shown that we can watch you, and I tell guys, if we do nothing, you will not even know that you have prostate cancer. And I'm not talking for a week or a month or a year, but I'm talking 5 years, maybe even 10 years before you might have signs of the fact that you have prostate cancer.